start, Amber?
जी मेरीन स्टार्ट.
Yes, please.
Bismillahirrahmanirrahim. Next slide. Don't go through life, grow through life. Quote of the day. My topic of presentation is experimental study designs. Learning outline. In this presentation, I'm going to introduce you to the study designs, and we are going to discuss in detail the experimental study designs, the advantages and disadvantages and drawbacks of the designs. At the end of the presentation, participants will be able to describe the experimental study designs, their advantages and disadvantages. Study design. A study design is a scientific plan or protocol for conducting the study which allows the investigator to translate the conceptual hypothesis into the operational one. This is the hierarchy of the study designs. At the bottom are the animal and lab studies, and then are the case report, case series, and cross-sectional studies, then case control studies and cohort studies. These studies have been discussed in the previous session. In this session, we are going to focus on the randomized control trials and other clinical trials. Experimental studies. These studies are different from the other studies because there is an intervention in the study. The intervention can be any medicine, which is a therapy. It can be any vaccine, which can be a preventive trial or an advice. An intervention is done on the study group as shown in the figure, and then the group is followed for the outcome. The outcome can be a change in the number of disease or the behavior change. Advantages of the clinical or experimental trials. These are used to evaluate new drugs. These new drugs can be compared with the existing drugs, or they can be placebo drugs, to evaluate the new treatment and therapies, to evaluation of the screening programs, and to evaluate primary prevention via intervention. Disadvantages. Experimental trials are expensive, they are time consuming, and they mostly address a narrow research question, and there are ethical issues, and they may pose a participants a potential harm as we are testing new therapies and new drugs. Experimental trials. In this presentation, we are going to discuss the randomized control trials, non-randomized control trials, crossover trials, and factorial designs. This is the brief overview. In a non-experimental trial, the outcomes are measured in the participants after the intervention, but there is no comparison group. In quasi-experimental trials, measures outcome of in the participant group and in the control group, but the key factor of randomization is missing in the quasi-experimental group. And lastly, the experimental trials, which are the randomized control trials, in which randomization is done for inclusion of participants in the treatment group or the control group, and it measures the outcome in both groups. This is the overview or diagram of the randomized control trial. A randomized control trial starts in a sample population, and after the deciding the population, randomization is done on who meet the inclusion criteria of the study design, and they are randomly allocated to group 1 and group 2. And in the first group, new treatment or intervention is done and they are followed up for the outcome. And in the control treatment, they could be the usual treatment which is already existing, or even placebo drugs can be given, and they are then followed up for the outcome, and the results of both the outcomes are compared. These are the steps of randomized clinical trials. The step starts with the choice of intervention, that which intervention we want to do on a group of people. It can be any drug, any therapy, any health message, any health promotion, and or anything. And then we choose the outcome measures. After the study has been done, which outcome measures are we going to compare in the experimental group and the control group. And then we will select the participants. We will set an inclusion criteria for the participants in the study, and we are going to measure the baseline variables. Then is the key step of randomized control trials, which is randomization. The participants will be randomly allocated to the experimental group or the control group, and then blinding can be done, which is discussed in detail later, and then intervention is done, and last step is follow up and the outcomes are measured. Randomization. Randomization is a process which ensures equal and known chance of being included in study group or the control group. Randomization eliminates a selection bias on the part of the researcher. It ensures comparability, and it minimizes both known and unknown confounding factors. These are few types of randomization. Number one is the simple randomization, that all participants which meet the inclusion criteria are randomly allocated to the intervention group or the control group. Second is the block randomization. In block randomization, we take intervention group and control group from each block. It is useful when we have a small sample size, so that number of participants in control or intervention group become nearly equal. In block randomization, blocks are made, and from each block, the intervention group and controls are selected from each block. And in stratified randomization, the stratas are made, and from each strata, intervention group participants and control group participants are selected. This is more detail about block randomization. The randomization method is designed to randomize patients into groups that result in equal sample size. It is useful when we are doing studies with a smaller sample size, and it maintains equal number of people in the intervention and the control group. Next is the cluster randomization trials, in which clusters, which are social units, or the clusters are randomly allocated rather than the individuals. It is shown in the figure that usually the randomization is individual randomization, in which two groups are made on individually. But in cluster randomization, clusters are made, and these clusters are then either put into treatment group or the control group. Then comes the blinding. Blinding is an important part of the randomized control trials. It prevents the bias on the part of the researcher, the participants. In a single blind study, the participants are not aware that whether they are being included into a control group or the experimental group. In a double blind study, the participants are not aware, and the researcher is also not aware that which of the participants are in study group and which are in the control group. In the triple blind study, nor participants, nor the investigator, and nor the monitoring committee is aware that whether the participant is in the individual group or the control group. And after analysis is done, then the third party reveals the result that which group has which outcome. This is a research study of a randomized controlled trial, hydroxychloroquine for early treatment of adults with mild coronavirus disease, a randomized controlled trial. In this study, they have compared the hydroxychloroquine with the usual therapy, and a randomized trial is done, and they have evaluated the outcome, that is the nasopharyngeal swab after 7 days of COVID-19. Next is the quasi-experimental model. This is also known as non-randomized clinical trial. It is similar to the randomized clinical trial, but the only factor missing is the randomization. There is absence of randomization, and the rest of the design is similar, that the study group has the intervention and the outcome is measured, and in control group, after having intervention, the outcome is measured, and the outcomes are compared in the both the groups, and but the only thing lacking is the randomization. Next clinical design is the crossover design. As shown in the figure, the study participants are enrolled, then randomization is done, and half of the participants are in group A and group B. And after the intervention, outcome is measured, and then after a certain period, the study participants in group B then receive the intervention ivermectin X, and group A they are then receive the ivermectin Y. In this way, the crossover is done, that all the participants receive both the intervention with a gap crossover. This is important because of the residual influence of the intervention on outcome after. Amber, I cannot see the screen.
Please start, Marie.
Next slide. This is a crossover study design. Next slide, Amber. The advantages, previous slide. The advantages of crossover design are that this allows within and between group analysis. In the previous design, we compared the outcomes of the study and control group, but this study design has an additional advantage, that is it is allowing us to do within group analysis, like the outcome is measured after treatment A and then at the end after treatment B. But the disadvantages are it is time consuming. As you can see that a double time is consumed for carrying out this as a study. It is more expensive, it may be complex to interpret, and there can be carryover effect, which is the residual effect of intervention after it has been stopped. Next slide. Next is the factorial design. It is used when we want to test two drugs or two interventions simultaneously. It is a complex design, and it has complex analysis as shown in the figure. The participants are divided into 4 groups. Number one group is the one which is going to get both the interventions, intervention A and intervention B. And in the group 2 is going to receive the intervention A only. Group 3 is going to receive the intervention B only. And the last group is neither going to receive the intervention A or intervention B. And for example, if we want to look the effect of beta carotene on and aspirin on treatment of MI, we can use this study design. And the additional advantage of that, the synergistic and antagonist effect of the interventions can be studied simultaneously, that whether two drugs have synergistic effect or they are blocking the effect of each other. So it is the complex design, and complex analysis can be done. Now comes the ways of expressing now comes the ways of expressing outcomes. Once we have done a clinical trial, we want to express the outcomes. There are a number of ways that we can express the outcomes. Number one is the efficacy. Efficacy is the performance of out or the outcome in the ideal lab conditions. And in effectiveness, the performance of an intervention in the real life or in the real world. And we can also apply chi-square test if there are outcomes. In outcomes, we have proportions in the control group and the intervention group. And depending upon our results, we can also apply t-test, z-test, and ANOVA if we have continuous outcomes in our result. We can also calculate relative risk, which is also calculated in cohort study if we follow for a certain outcome in the experimental and the control group. Survival curves can be made, and number needed to treat and number needed to harm are also ways of expressing the outcomes of the clinical trials. This is a survival curve. If we have two interventions for a certain disease, we can also express the outcome in the form of survival curve. In the black line, this is a survival curve for treatment A, and the red dotted line shows the survival curve of the treatment B. And next slide. Number needed to treat. This is a way of expressing the outcome of the experimental control trials. We think that from clinical trial, we will get the conclusion that whether this therapy or drug was effective or not for the disease and the study. But in reality, therapies work differently for different people. For example, in COVID-19, ivermectin was used to decrease the severity of disease. If we give therapy to a group of people, it may work for some, but not all. So one way to express the outcome of clinical trial is number needed to treat. So number needed to treat is the number of people which we need to treat to get one benefit. Like for example, if we are treating 5 people, so only one of them will get benefit. This is a table. Treatment and the outcome is shown. And we have calculated experimental event rate, like if we get the outcome in experiment, and control event rate. Then we calculate the absolute risk, which is the controlled event rate minus experimental event rate, and number needed to treat is 1 over absolute risk. Next slide. So this is more about the calculation about number needed to treat. We from the definition of response, example improvement and stabilization of SIB scale, we calculate the number of patients under the intervention, which is the memartine, and under placebo, which is the control group. And we calculate the percentages to be 50% in the experimental group and 25% in control group. So the number needed to treat is 1 over 50% minus 25%, which turns out to be 4, which shows that 4 persons must be treated to get the benefit. Next is the number needed to harm. The number of people we need to give therapy in order for one person to get the adverse outcome. The concept behind this is when interventions are done, there are adverse outcomes. Even with antibiotics, we get diarrhea, and every medication has one or more adverse effects. Now, for quantification of the adverse effects, we quantify the adverse effects by number needed to harm, which is the 1 over absolute risk increase. Now, we are going to discuss the different stages of clinical development. Number 1 is the phase 1 trial. In phase 1 trial, we check for safety of the drug in 10 to 20 healthy volunteers. And then after that, we check the, in phase 2 trial, we check for the efficacy in about 200 participants. And those interventions who pass through phase 2 trial enter the phase 3 trial. In phase 3 trial, it is a large, usually randomized controlled trials, and we confirm the findings in a larger population. And in phase 4 trial, the product is in the market, and the long-term safety and post-marketing surveillance is done in the phase 4 trial. Classification of clinical trials. Before phase 1 trials, we have preclinical studies. Preclinical studies are done in labs, and animal testing is done in preclinical studies to evaluate for carcinogenicity and tetragenicity. In phase 1 trials, we want to check the safety of the drug. So without therapeutic objectives, we are not checking the therapeutic objectives. We are just injecting or doing the intervention in a small group of population to see whether the drug is whether the drug is safe, and we establish the minimum safe dose. And in phase 2 trial, we check the efficacy. A small number of persons are given the drug, and the efficacy is monitored. Next slide. In phase 3 trials, these are the studies which are done in the larger population, and usually randomized clinical trials are done in the phase 3 trials. For example, in UHS, they were testing the vaccine CanSina Bio, and half of the people in that trial were given the vaccine, and half of them were given the placebo, and they monitored the outcomes after a certain time period. In phase 4 trials, once the vaccine or the intervention or the drug has entered the market, we need to evaluate the long-term safety of the drug or the vaccine. So that enters the phase 4 trial. The post-marketing surveillance is done in this phase. This is again a picture of coronavirus vaccine tracker, in which there are a number of vaccines in different phases. In preclinical cases, and animal testing is done. In phase 1, small number of people were given the vaccine to check the safety and dosage. In phase 2, hundreds of people were given to see if vaccine worked differently in them. So the efficacy was tested. And in phase 3 trials, there were thousands of people were see the effectiveness of the drug, and a randomized controlled trial was done for it. Now it's time for the MCQs. A group of college students is working on vaccination for COVID-19. After preparing the preparation of vaccine, they have injected it in monkeys. In which phase of trial are they in? Preclinical testing, phase 1.
Preclinical.
Yes, the
Preclinical.
correct answer is preclinical testing, because preclinical testing, lab results and animal testing is done. Next MCQ. Sinopharm vaccine is being injected for prevention of COVID-19 in Pakistan. After 5 years, in 2026, the government compiled a report on effectiveness and adverse events and disadvantages of vaccine. They are results of which phase of trial?
Phase 4.
Phase 4.
Yes, the correct answer is phase 4. Post-marketing surveillance of an intervention is done in phase 4 trial. Aspirin can reduce the incidence of ischemic heart disease. A randomized controlled trial was done which showed that after using aspirin for 3 months, 40% developed ischemic heart disease, while a group receiving placebo showed that 54% developed ischemic heart disease. Calculate the number needed to treat. Number needed to treat is 1 over absolute risk reduction. For this, we have seen that incidence outcome was 40% in the experimental group and 54% in the control group. So absolute risk reduction is 14%. Like this drug has reduced the risk by 14%. So number needed to treat is 1 over absolute risk reduction, which comes out to be 7.14. So we need to treat 7 patients with aspirin in order to prevent 1 ischemic heart disease event. Identify the study design as shown in the figure.
Crossover.
Yes, the correct answer is
Crossover.
crossover, because in this design they have enrolled the subjects and they have randomized, and then they have given the treatment and treatment B in both groups, and after a washed out period they have done the treatment again. Randomization in RCT is the most important step, which is not true for randomized controlled trial.
D.
No, the correct
D.
answer is D. No problems of attrition. Randomization eliminates selection bias. It ensures the comparability between both the groups, and relative risk can be calculated in as an outcome. But there are problems of attrition. Number 6. A study was done on ivermectin effectiveness in COVID-19 patients. The participants were not aware whether they were in study group or control group. This is a
Alpha. Alpha.
Single blind.
yes, it's a single blind study, as the participants are not aware. An antibiotic for treating pneumonia in children less than 5 years of age is causing diarrhea in 20% of children who received antibiotic, while 15% of the control group developed diarrhea. The best way to quantify the adverse effect of therapy is
B.
the correct answer is number needed to harm. So we have already discussed that we quantify the adverse effect by number needed to harm. Identify the study design as shown in the figure.
Case control study, like cohort study.
Yes, it's a cohort study. It's starting with an exposure, but there is no intervention. The study design of interventional trial is also the same, but there's intervention. And in cohort study, the word used is exposure. Which of the following clinical trials should not be done? Um,
B,
the clinical trials, if we are doing a new treatment, we do not want to be inferior to the competition. Inferiority trial should not be done. Non-inferiority trial or equivalent trials can be done, the results are same, but the cost of the intervention is cheaper. So the non-inferiority or equivalence trials can be done, and superiority trials are also done. Which type of study design is this?
Randomized control trial.
It's a cross-sectional study, defined population. We have gathered the data on exposure and disease simultaneously, and we have divided it into 4 groups. In case control group, we start with the cases and controls. Thank you.
Thank you very much, Dr. Mehreen. It is a wonderful presentation as always, and its graphics, presentation technique, everything was wonderful. The most important advantages of your presentation was we have a very clear understanding about the experimental study designs, their types, the types of randomization has been beautifully explained, types of blinding, the especially you have talked about the crossover study design, washout period, as well as the factorial study designs. However, I think that the more detailed discussion is required for factorial study design. And there you have talked about the outcome measures. I have shared one of a very important outcome measure slide that is being used in most of the outcome measures in randomized clinical trial in postgraduate group. Please go through that outcome measure. However, I have few important observations about your presentation. First is you have talked about inferiority study designs. Yes, inferiority trials, they are usually done when a drug is in practice and there is an evidence that is required in order to replace that drug with some more effective drug. So inferiority trials are also very important trials whenever the management is being done for certain important conditions and its medicine or its drug needs further evidence to practice. The second important thing is about you have talked about the crossover trials. I also want to know more about the self-control trials. What are the self-control trials, Dr. Mehreen?
Ma'am, in self-control trials, before an event, the participant, the baseline is itself taken as the control period, and when the event happens, that is taken as the intervention time. And
Very rightly said. The self-control trials are the studies in which the same group works as the control group. And the important is the point the most important point is that the control options are present within the group. So the moderate level of control can be obtained by using the same group of the subjects for both the experimental and control options. So whenever we are using crossover study design, you have talked about the washout effect. Yes, it is very important. Another important issue that we usually have to face is about the order effect, the order in which the treatments are being offered or administered. They also can affect the outcome. For example, we know that there is a natural history of disease. There, if there is any outcome measure like fever, pain, etc. So the first drug that would be offered would causes more decrease in the pain, and the second drug that would be offered after some time would not be able to produce such a big difference. The reason is that with time, the pain or fever or certain outcome measures, they start settling down. So even after the washout period, the most important point that we have to consider is the order effect, that it may be the order of the drug that is producing bias. You have wonderfully talked about the number needed to treat and different formulae that are being used. I always think that whenever we use NNT in our study designs, we always take into consideration about the relative risk reduction, about the control event rate, about the experimental event rate, about the relative risk, and about the absolute risk reductions. So all these things, they go hand in hand to decrease or increase the advantages or disadvantages with the randomized control trials. As we all know that advantages give us a strong